Good afternoon to you all. Today we are going to discuss drug use disorders, topic being drug dependence and drug abuse, part 1. Coming to the important terminology of drug use disorders, such as misuse. What is misuse? Non-logical, thoughtless, random, unplanned use of any drug or substance other than a CNS stimulant or depressant drug without careful judgment is called its misuse. Example: misuse of laxatives, purgatives, or of antibiotics, etc. Coming to the next terminology, abuse. What is abuse? Misuse of any CNS stimulant or depressant drug or substance or behavior, like the thrill of gambling, hearing music or playing musical instruments, viewing sex related videos, usually by teenagers or young adults, etc., is called abuse. Now, coming to the next topic, reinforcement or reinforcing behavior. The properties or capacity of drugs responsible for drug seeking behavior are called reinforcement. There are drugs which have capacity to increase neuronal activity in mesolimbic dopaminergic pathway in the brain, also known as brain reward reinforcement pathway, due to which the user is compelled to get more of the drug again and again. Depending upon clinical features, reinforcement can be further divided into two types: positive reinforcement and negative reinforcement. Now, coming to the first type, positive reinforcement, also called euphoria. It is the experience of pleasure or excitement, an intense feeling of well-being and happiness. Coming to the next type, negative reinforcement, also known as dysphoria. It is a state of unease, unwell, unhappy, or generalized dissatisfaction with life. It is a symptom, not a medical diagnosis, as seen with a variety of mental disorders such as anxiety, depression, mania, etc. Coming to the next point, abuse potential. Abuse potential, the evaluation of drugs for their reinforcing properties forms the basis for assessing their abuse potential. Abuse potential of drugs is qualitatively divided into following types depending upon their severity: a strong abuse potential, moderate abuse potential, and mild abuse potential. Coming to the next topic, habituation. What is habituation? Habituation has following characteristics: the harmful effects of the abused drugs or substances are restricted to the user himself or herself and not to the family or society. There is no intense craving for seeking the drug. There is no development of tolerance. There are no distressful withdrawal effects. Example of habituation producing drugs is taking tea and coffee. Coming to the next point, addiction. It is characterized by following features: harmful effects of the drug not only harm the user but the family and the society as well. There is always an intense craving to procure the drug by any means. There is development of tolerance, so a need to increase the dose to get same previous effects. life-threatening or alarming withdrawal symptoms after cessation of drug. So physical and psychological dependence both are present. Here is the important point to note. According to Diagnostic and Statistical Manual of Mental Disorders, 5th edition, American Psychiatric Association, 2013, and WHO, all old terms like habituation, misuse, addiction, etc. have been deleted, and most recently new terms substance abuse instead of drug abuse and substance dependence instead of drug dependence have been introduced. Coming to the substance abuse, one or more of the following symptoms must be present for the diagnosis of substance abuse. These are recurrent substance use resulting in a failure to fulfill his or her major obligations at work, school, or home. Example, repeated absence or poor performance at work, expulsion from school. Recurrent substance use even in situations where it should not be used. Example, during driving, operating a machine, or operating upon the patient. Recurrent substance use despite punitive or punishable action. Next feature, recurrent substance used despite having interpersonal and family problems. Examples, physical fight with a spouse about the consequences of abuse. Coming to the next important topic, substance dependence. At least 3 of the following symptoms must be present for diagnosis of substance dependence. Development of tolerance, first. Next, distressful abstinence syndrome after cessation of the abused drug. Increased craving for the drug or failure to cut down its use. Substance use in larger amounts than intended. Next point, withdrawal from social, occupational, or recreational activities. Further point, giving much time for searching and obtaining the abused drug, which become lifestyle of the user. Example, visiting multiple doctors, quacks, or his contacts in illicit drug trade. Continued use of the abused drug despite health, social, economic, family, and legal problems resulting from substance use. Now coming to the types of substance dependence. There are 2 types. Coming to the psychological dependence, which is characterized by moderate compulsive drug seeking behavior for personal satisfaction. Example, cigarette smoking. Tolerance may or may not be present, and if present, it is usually either pharmacokinetic type or tachyphylaxis, but rarely pharmacodynamic. Withdrawal effects are less frequent and mild, never life-threatening. Coming to the physical dependence, which is characterized by intense craving for the drug. Examples, alcohol and opiates. Tolerance is always present, always pharmacodynamic type. Withdrawal effects are severe and distressing and opposite to those sought by the abuser. Psychic dependence appear prior to physical dependence, usually. Coming to the next point, cross dependence. The ability of the drug to suppress the withdrawal features produced by another drug is called cross dependence. Now coming to the point dependence. It is a physiological state of neuroadaptation resulting from repeated use of abused drug, compelling the patient for its continued use to prevent the withdrawal syndrome, which is manifested as opposite to the pharmacological effects of the drug. Now coming to the next topic, tolerance. It is the requirement of higher dosage of a drug to produce a given response initially produced by a smaller dose. Types of tolerance, mainly two types, innate or natural tolerance and acquired tolerance. Innate or natural tolerance, genetically determined lack of sensitivity to a drug. Example, rabbit shows tolerance to atropine. Black race are tolerant to mydriatics. Acquired tolerance, it develops on repeated administration of a drug. The patient initially responsive to a drug later becomes tolerant. Acquired tolerance is further divided into following types: pharmacokinetic tolerance, tolerance due to changes in the absorption, distribution, metabolism, and excretion of the drugs. Examples being barbiturates. Pharmacodynamic tolerance, also known as functional tolerance, where the tolerance is due to changes in the pharmacodynamic effect of the drugs. Examples being opioids. Reverse tolerance, also known as sensitization. Example being cocaine and amphetamine. Coming to the next point, cross tolerance. When tolerance to primary drug developed, then the user also shows tolerance to another members of the same group of drugs. Example, person tolerant to morphine also shows tolerance to other opioids. Chronic alcoholics are also tolerant to benzodiazepines or even general anesthetic agents. Next point, learned tolerance. It is observed when some addicts practices to walk in a straight line, but it is only found in mild to moderate users. Example, in alcoholic persons, but severe addicts fail to conceive or suppress features of alcoholism. Now coming to the next terminology, here being rebound. Exaggerated manifestation of the original disease symptoms immediately after discontinuation of the drug used for the treatment of that disease is called rebound. Example, rebound hypertension after sudden discontinuation of beta blockers or clonidine. Next term is relapse. Recurrence of same disease clinical features after discontinuation of the treating drug. Example, sudden stopping of insulin will produce relapse of diabetes mellitus. Now coming to the next point, detoxification. Slow tapering dose of the abused drug will usually not produce withdrawal symptoms, even though they produce withdrawal symptoms on sudden discontinuation. Now look at this table showing multiple simultaneous variables affecting onset and continuation of drug abuse and addiction. Etiology of substance use disorders include mainly three factors, namely agent or drug factor, host or user factors, and third one, environmental factors. Variables of agent factors are the abuse liability of a drug, is directly proportional to rapidity of the drug action. For example, chewing coca leaf produces delayed and low blood levels, so usually no behavioral problems occurs. However, when coca alkaloids are taken by inhalation, then blood levels produced is almost equal to the intravenous administration of coca, producing serious behavioral problems. Now coming to the agent or drug factor, there are so many variables such as availability of the drugs, cost of the drugs, purity and potency of the drugs, mode of or route of administration of drugs, which include chewing, absorption via oral mucous membranes, gastrointestinal, intranasal application or route of administration, subcutaneous and intramuscular route of administration, intravenous administration, and inhalation. Next point, speed of onset and termination of effects has been just discussed. Now coming to the next factor, that is host or user factor. Different variables under this topic is heredity, innate tolerance, and speed of developing acquired tolerance, likelihood of experiencing intoxication as pleasure. Next point is metabolism of the drug, nicotine and alcohol that are already available, psychiatric symptoms, prior experiences or expectations, propensity for risk-taking behavior. These all are host factor variables. The third one is environmental factors, and different variables under environmental factors are social settings, community attitudes, peer influence, role models, availability of other reinforcers, source of pleasure or recreation, employment or educational opportunities. Examples, some users or some new users are given employment to work in this illegal drug abuse markets. Conditioned stimuli, environmental cues become associated with drugs after repeated use in the same environment. Look at this figure. Here is the diagrammatic representation of shifts in a dose response curve with tolerance and sensitization. The solid black curve of the middle describes the dose response relationship to initial dosage, the control curve. With tolerance, there is a shift of the curve to the right such that higher doses are required to achieve equivalent effects. Examples being opiates drugs. With sensitization, the dose response shifts to the left and a given dose produces a greater effect than in the control case. Example being cocaine. Now coming to the next topic, designer drugs. These drugs are synthetic substances prepared in clandestine laboratories that are inexpensive to produce and difficult to detect. Such molecular manipulations of the widely abused drugs are done illegally by some chemists to avoid Drugs and Narcotics Act regulations and to make huge profit. These include MDMA, 3,4-methylene dioxymethamphetamine, known as ecstasy. Another example is China white, which is an analog of fentanyl with its potency 1000 to 1500 times than that of fentanyl. Now coming to the next most important point, drugs of abuse producing dependence. They are classified into following categories depending upon types and grading of dependence, withdrawal symptoms and tolerance, etc. Agents having only mild psychological dependence with low withdrawal effects and no physical dependence is the first type. Example being coffee, tea, cigarette smoking up to 10 cigarettes per day without inhalation. Second being agent with moderate to severe psychological dependence with low withdrawal and slight physical dependence. Examples of second category are marijuana or hashish, psychic dependence mild plus physical dependence doubtful plus tolerance may or may not develop. LSD, the other example, where psychic dependence is mild plus with LSD physical dependence is nil and tolerance may or may not develop. Amphetamine, cocaine, psychic dependence severe plus physical dependence mild plus tolerance mild. Nicotine, 20 cigarettes or more per day with inhalation. Psychic dependence severe plus physical dependence mild plus withdrawal effects low. Nicotine, depending upon the number of cigarettes per day smoked, the features or categories differs. When the number of cigarette smoking is not more than 10 cigarettes per day, then it comes under the first category, while when the number is more than 20 and with inhalation routes, then it comes under the second category. Inhalants such as lacquer paint solvents, petrol, nail polish remover, or any pressurized aerosol or liquid petroleum gas. Here, psychic dependence moderate plus physical dependence nil plus withdrawal effect low plus tolerance may or may not be present. Coming to the third category, C, agents having moderate to severe psychological dependence with mild physical dependence. Drugs under this category are benzodiazepine groups of drugs, where psychic dependence moderate plus mild physical dependence on prolonged and moderate use plus tolerance. Alcohol when it is taken in moderate dosage. Severe psychic dependence plus mild physical dependence plus mild withdrawal effects plus tolerance. Next category is D, agents having severe psychological and physical dependence. Examples are opiates, severe psychic and physical dependence, pharmacodynamic tolerance marked, plus severe withdrawal effects which are precipitated by naloxone. Barbiturates are the other group where features are severe psychic and physical dependence plus severe withdrawal effects plus pharmacokinetic type of tolerance. Next group is alcohol when it is taken in heavy dose. Severe psychic dependence plus moderate physical dependence on prolonged use plus severe withdrawal effects plus tolerance. Now look at this figure number 2 showing CNS counter adaptation after drug abuse. And in this figure, mechanisms for the development of tolerance, dependence and withdrawal effects have been shown. In the major areas of the brain, usually there is a balance between an excitatory denoted in this figure by E and inhibitory denoted by in this figure by I neurotransmitters as shown in state 1 of this figure, and body try to counteract the stimulant or depressant effects of the abused drugs by increasing the inhibitory or excitatory activity respectively. In this figure, the abused drug shown is inhibitory, denoted in the figure by IT, which mimics the inhibitory neurotransmitter I. As a result of its primary action, the balance is altered to a state of inhibition I plus ID as denoted in state 2. After prolonged use, the body tries to increase the excitatory activity as counter adaptation shown in the figure by E plus E, that is excitatory neurotransmitters. The balance E plus E is equal to I plus ID is now restored as shown in state 3. If this drug denoted in this figure by ID is suddenly withdrawn, a disbalance occurs producing withdrawal effects as shown in state 4. The latent hyperexcitability is now unmasked E plus E because physiological restoration of normal balance would take its own time. The biological restoration to normal levels could also be achieved by proper treatment as shown in state 5 of this figure. Now coming to the next topic, neuropharmacological adaptations during dependence. Chronic use of abused drug induces adaptive changes in the neuronal signal transduction pathways responsible for drug dependence. Coming to the first abused drug, alcohol. Chronic exposure to ethanol leads to compensatory increase in the density of NMDA receptors and L-type voltage-gated calcium ion channels in the brain. This leads to neuronal hyperactivity observed during alcohol withdrawal. NMDA and L-type of calcium channel antagonists, example A camprosate, an NMDA receptor antagonist, decreases the neuronal hyperactivity observed during alcohol withdrawal. So these antagonists are used during treatment of alcohol withdrawal symptoms. Chronic use of ethanol also downregulates the GABA A receptor activity. This is also responsible for withdrawal effects. So benzodiazepine having GABAergic activities reduce withdrawal symptoms. Next point, ethanol also upregulates cyclic AMP mediated signaling in other brain areas including midbrain, ventral tegmental area denoted by VTA and nucleus accumbens. It also inhibits central neuronal nicotinicholinergic receptors. Look at these two figures. First, coming to figure number 3, showing metabolism of ethanol with sites of action of the antagonist. Ethanol is converted to acetaldehyde mainly by the enzyme alcohol dehydrogenase, but also by mixed function oxidase. Acetaldehyde is further converted to acetic acid in the presence of the enzyme aldehyde dehydrogenase mainly, but also by aldehyde oxidase enzyme. And acetic acid is further divided into carbon dioxide and water. Inhibitor of alcohol dehydrogenase, omeprazole inhibits conversion of ethanol to acetaldehyde, and disulfiram is the another drug which inhibits aldehyde dehydrogenase, preventing conversion of acetaldehyde to acetic acid. So accumulation of acetaldehyde gives rise to many clinical features of alcohol poisoning. Now coming to the figure 4, in which metabolism of methanol with drugs used in the treatment of methanol poisoning has been shown. First, drug ethanol is a competitive inhibitor of alcohol dehydrogenase. Other drug, omeprazole, is non-competitive antagonist of alcohol dehydrogenase. So, formic acid formed as an end metabolite of methanol causes acidosis, retinal damage, nausea and vomiting. So, ethanol and omeprazole are used in the treatment of methanol poisoning. Additionally, vitamin B1 and other vitamin B complex, parenteral or oral glucose, maintenance of serum electrolytes, correction of metabolic acidosis are also very important in the general management of alcoholism. Now coming to the next topic, alcohol withdrawal syndrome, which include following clinical features: alcohol craving, tremor and irritability, nausea, sleep disturbance, tachycardia, hypertension, sweating, perceptual distortion, seizures, which usually occur in between 6 to 48 hours after last drink, visual hallucinations, and occasionally also auditory or tactile hallucination usually occur in between 12 to 48 hours after last drink, and delirium tremens, which occurs after 48 to 96 hours of last drinking, rare in uncomplicated withdrawal. Severe agitation, confusion, fever, profuse sweating, tachycardia, dilated pupils, nausea and diarrhea all are the features of delirium tremens. Now coming to the next point, management of chronic alcohol withdrawal syndrome and dependence. First point, management of withdrawal syndrome. Diazepam or chlordiazepoxide given intravenously or orally. After management of acute withdrawal features, dose is tapered gradually over months. Clonidine, an alpha-2 receptor agonist, acts by inhibiting the exaggerated neurotransmitter release that occurs during withdrawal. Beta blockers antagonize the increased sympathetic activity. Clonidine and beta blockers both decrease tremors, palpitation, anxiety, and other hypersympathetic features. Rimonabant, a cannabinoid 1 receptor antagonist, also useful in alcohol withdrawal. Now coming to the next point, management of alcohol dependence. These are aversion therapy by disulfiram. 1 gram first day oral dose, then dose is gradually reduced by 200 mg per day to achieve maintenance dose of 200 to 250 mg once daily. Now coming to the next drug, naltrexone, an opioid receptor antagonist, dose 50 mg once daily orally. It decreases craving for alcohol. A long-acting intramuscular preparation also available, given once per month. Nalmefene, another opioid receptor antagonist, also used in place of naltrexone. Next drug is topiramate, an anticonvulsant. It potentiates inhibitory effects of GABA. Next drug is acamprosate, which is an NMDA receptor antagonist, useful in preventing relapse. Dose 333 mg tablet, usually 1 to 2 tablets thrice daily. It also possesses some opioid antagonist action. It also increases 5-HT3 levels in the synapse. Side effects of acamprosate is GIT upset and skin eruptions. Another drug is ondansetron, a 5-HT3 antagonist, also decreases craving. Baclofen is another drug, a GABA B receptor antagonist, also useful. Dose being 20 to 40 mg per day. Fluoxetine, a SSRI, a specific serotonin receptor inhibitors. It increases serotoninergic activity in CNS. Rimonabant, a cannabinoid 1 receptor antagonist, also useful in alcohol withdrawal. Next point is psychosocial therapy and counseling by a psychologist also help. Thank you.